Yes, thank you very much for this very nice introduction. My topic today is to restrict to autologous stem cell transplantation in lymphoma, so that's what I'm talking about. Here you have a nice view from Heidelberg. Greetings from Tony Ho, who actually is living there somewhere. Now retired, by the way, since a few months. So what will I tell you today? I will speak for a longer while on standard indications in non-Hodgkin's lymphoma. I will skip Hodgkin's lymphoma in the interest of time, but also because in our center at least, Hodgkin's lymphoma is now the only on the fifth place in indications for autologous transplantation after myeloma, non-Hodgkin's lymphoma, amyloidosis, autoimmune diseases, and only then comes Hodgkin's lymphoma. We have only a handful of autotransplants for Hodgkin's in the last few years. And if there's some time left, I would touch on some special situations like HIV-infected patients and double-hit lymphoma, which of course is an orphan disease, but I'm always asked about transplant in double-hit lymphoma. That's why it's on the agenda today. So what are the main indications within Europe or within the EBMT, which covers more than Europe? This is a slide capturing the status in 2014, because for that year we have the complete numbers all together, and you can see that diffuse large B-cell lymphoma is the main indication or the most frequent indication in Europe with more than 1,800 autotransplants per year. Then comes Hodgkin's, so the situation in Heidelberg or Germany may be different than in the rest of Europe. Then the third frequent indication is mantle cell lymphoma, followed by follicular lymphoma, T-cell lymphoma, and CLL has almost disappeared from the auto-transplant map. Altogether, almost 6,000 autografts have been performed in Europe in the year 2014, and there you can see the kinetics. So altogether already 2 years ago, autologous transplant in lymphoma was going down a little bit, of course most pronounced in CLL, but also in follicular lymphoma, Hodgkin's lymphoma, only peripheral T-cell lymphoma and mantle cell lymphoma had some increase in numbers. Coming to the standard indication, I will only talk about standard indications today for autologous transplantation, and here you have the most recent EBMT catalog, so to say. It has been expected that we will have another version this year, but probably we have to wait for next year. So this is the 2015 version, and there you can see that for diffuse large B-cell lymphoma, the standard indication is chemosensitive relapse or chemosensitive relapse beyond first line, of course. So there has been some rumors about the CORA trial because it suggested that those patients who had a prior rituximab before relapsing had a poorer prognosis, and indeed this is the case. If you look at this curve from the JCO publication in yellow, you can see those patients who had prior rituximab and then had a relapse, mostly an early relapse within the first year after primary treatment. And there you can see by intent to treat, the outcome is significantly worse than compared to those patients who had rituximab naive induction treatment. So the question was, is in the rituximab era autologous transplantation still an option for relapse or refractory diffuse large B-cell lymphoma patients? And I will present you two. A registry study, one from the CIBMTR, which is this one, and they were addressing early failure of frontline rituximab-containing chemoimmunotherapy in diffuse large B-cell lymphoma. And early failure means relapse within 1 year, and late rituximab failure means relapse beyond 1 year, and they had more than 500 patients. 300 were in the early failure group, and the remainder was in the later failure group, which reflects clinical reality, so to say. And here you can see that if these patients were in remission, were responding to salvage chemotherapy, there was no significant difference beyond the first 9 months after transplant. So if you do the type of landmark analysis, you will see that those patients were starting here, that there is no significant difference in the long term. There was a significant difference in disease control because of more relapses in the early failure group, but still the outcome was quite encouraging with 44% 3-year progression-free survival, and for that reason the colleagues from the US or from the other side of the Atlantic concluded that autologous transplant provides durable disease control to a sizable subset of diffuse large B-cell lymphoma patients, even if they had an early rituximab failure. And for that reason, autologous transplant remains the standard of care in chemosensitive lymphoma, regardless of the timing of disease relapse. And at the EBMT, we made a more or less similar study, which was in a way twofold. We compared autologous transplantation for relapsed diffuse large B-cell lymphoma by era, meaning before 2001 and after 2001. And in the latter era, we compared also autologous transplantation with allogeneic transplantation as a first transplant strategy, focusing on those patients who directly went into an allogeneic transplantation after relapse without having an autologous transplantation. So the first question, with a very huge number of patients, more than 6,000 patients you can see here, and the both eras were quite comparable in terms of age, performance status, refractoriness at stem cell transplantation. However, the more recent series was more heavily pre-treated, and there was a shorter interval between diagnosis and transplant in the more recent series. And this is now the progression-free survival. You can see there was virtually no difference between the pre-rituximab and the rituximab era. And actually, there was a trend in favor of the latter series, meaning that those who had a rituximab pre-treatment, or at least were treated in the rituximab era, had a slightly better outcome than those who have been treated before. Then the comparison between autologous transplantation and allogeneic transplantation, meaning myeloablative and reduced intensity conditioning, depicted here separately. Of course, these first allo transplants were much, much fewer in number, and there was also some other unfavorable factors in the allogeneic groups, with more patients having a poorer performance status, with significantly more patients, almost double, who had a poorer disease status as transplant, and also the pre-treatment was much more pronounced in those patients who had an allograft. So these groups were not really well comparable, and that might explain why in all settings autologous transplantation was the superior choice in diffuse large B-cell lymphoma as a first transplant. So we didn't find any evidence or any hint that might favor going directly to an allotransplant, skipping the auto step, even in refractory patients. I didn't show that, but also in the refractory patients, there was no benefit for using allogeneic transplantation as a first transplant. So this came out of this retrospective study, which of course has many limitations. So it's not the evidence for the policy never do an allogeneic transplant as a first transplant in relapsed diffuse large B-cell lymphoma, but on the other hand, it doesn't support this strategy, of course. So I can skip that and jump to mantle cell lymphoma, where autologous transplantation, at least in the younger patients, is standard of care in first-line treatment. And here you have the reason why. This is an old study from the Munich group, from the Wolfgang Hidemann group, which finally showed, it's actually not a single study, it's a pooled analysis from 3 studies, which finally showed an overall survival benefit of those patients who underwent autologous transplantation as first-line, in first-line treatment for mantle cell lymphoma. And part of this was collected during the pre-rituximab era, so there is some, it's not this most solid data which one would like to have. Nevertheless, it's considered as standard in mantle cell lymphoma. Here you have the overall survival advantage at 5 years, 14%. And then we had this large, successful prospective trial by the European Mantle Cell Network, the MCL Younger trial, which was finally published in the Lancet by Olivier Hermine. And there was a big benefit for the intervention group, which means, or the experimental group, so to say. Here it was not a comparison transplant versus no transplant. So all of these patients underwent transplant, at least were intent to transplant. But one group received cytarabine as part of the induction regimen plus rituximab, and the other, that was the so-called French regimen, and the other half received cytarabine-free induction regimen, which was consisting of R-CHOP, more or less. That was the German regimen. And you can see that the French regimen was significantly better in terms of disease control. This, unfortunately, did not translate into an overall, into a significant overall survival benefit. But nevertheless, it is very clear that those patients who had cytarabine, high-dose Ara-C, had a better disease control than the others. And this might suggest that there could be some durable disease control, but if you look at this very long follow-up from the Nordic group, the MCL2 15-year follow-up, you can see that in all group, maybe except for the high-risk MIPI group, which is here down below, there are a continuous pattern of relapses. So even after 12 or 14 years, you will have some events here, which is not secondary malignancy. And that suggests that with autologous transplantation, even if you use all necessary components, including rituximab and Ara-C, you have no curative treatment at hand in mantle cell lymphoma with the auto transplant. That's why we need some improvement. And here you have the so-called triangle trial, which is currently about to start or has already started in some European countries, coordinated by the European MCL network, where this is now the standard arm, which is the winner of the MCL Younger trial. I've just shown you the data. And then you have this middle arm, and these patients receive ibrutinib in addition to autotransplant and Ara-C-based induction treatment, and they receive some ibrutinib maintenance. And then we have another experimental arm omitting the transplant, so just trying to test if transplant is still necessary if we have ibrutinib in the induction and the maintenance regimen, and we are very curious what will come out of this. So in the relapse setting, also autologous transplantation is considered as a standard indication in mantle cell lymphoma, and this is one study, a registry study again from the CRB-MTR, showing why. Here in gray you have those patients who receive autologous transplantation as first transplant intervention in relapsed mantle cell lymphoma, and in brown you have those patients who received an allotransplant as first transplant intervention. And it seems, at least from this study, that those patients who receive an auto transplant do not worse than those who receive an allo transplant, suggesting that if there wasn't an auto transplant in first line, autologous transplantation may be a good choice in these patients. So what about maintenance treatment with rituximab after autografting for mantle cell lymphoma? This is the LIMA trial by the LISA group, coming from French, has been presented at the ASH, and I think the main publication is also out. This just is a very straightforward randomization between those patients who undergo this standard induction and autografting regimen, followed by rituximab maintenance, yes or no. And here you have the results. There was a significantly benefit in terms of event-free survival from the time of randomization for those patients who had rituximab maintenance, which had, after 3 years, more than 80% event-free survival, which was around 70% or so in the observation group, so still a clearly a benefit. And this was most pronounced in those patients who were MRD positive or still MRD positive before auto transplant. So these are the blue patients. They were MRD positive post-transplant, did not receive rituximab maintenance. And in green here, not so easy to see, these are the patients who were MRD positive prior to transplant and then received rituximab maintenance. So it seems that in these patients, the maintenance is particularly beneficial, whereas in those patients who are already MRD negative prior to transplant, the difference between maintenance yes and no is not that strong, and it's questionable if this is significant. So just in a nutshell, autologous transplantation in mantle cell lymphoma is considered as standard in first-line and second-line therapy if there was no auto transplant already during first-line treatment. It should be done in the first-line treatment based on an RSC and rituximab induction regimen. It doesn't appear that there is a curative potential with autografting in mantle cell lymphoma, and rituximab maintenance may increase disease control. Follicular lymphoma, not such a frequent indication for autografting as it used before, as I have shown you, considered as standard indication in chemosensitive relapse, not in first-line treatment. And again, asking the question for cure, where we said no for mantle cell lymphoma. So what data do we have? This is some long-term data already several years ago, that since that was published, where you can see that in the relapse curve, there obviously are plateaus. This is some very long-term data pooled from the Boston and the BATS series, with no events beyond 8 years or so, and similar observations were made in Heidelberg, where we had also after 7 years or so, no relapse event. And those patients who underwent MRD testing at that time, most of them were MRD negative, suggesting that there is a very good disease control. And what about rituximab maintenance? There also we have a prospective study, which is the LIM-1 trial by the EBMT, published in the JCO 4 years ago. And now we have done, so this is the schema of this trial. It was a little complicated comparing two, having two randomizations. So first we had a randomization between an in vivo purging with rituximab, yes or no. So these patients received a dose or two of rituximab prior to PBVC collection and the others not. And then there was a second randomization for rituximab maintenance, yes or no. So altogether we had 4 arms. And this is an update. This is still a secret, but you won't tell. This will be presented now at the Lugano meeting. And this is the 12-year follow-up. I think this is very substantial. Again, you can see whether or not rituximab maintenance is given. There is only very few relapse events beyond 8 years, so very few. But most impressive is that the early disease control benefit we gain with rituximab is not compensated by late relapses or offset by late relapses. So it seems that the early rituximab, these 2-year rituximab, indeed can provide cure in a way, because the relapse risk of those patients who have maintenance rituximab is only half as high as those who haven't seen any rituximab. So I think this is very remarkable, and this may change practice. What about the type of high-dose therapy? Of course, TBI was in the old days the treatment of choice, and the problem with TBI was, as at least here and also in other studies, also very huge number of patients. Here, I don't think this is correct. No, this is only 593 patients. No, it's not 7,000. But finally, it turned out that although TBI patients had a lower risk of relapse after follicular lymphoma autografting, they had a poorer overall survival, and this was due to a higher risk of secondary malignancies. So these transplants were performed between 85 and 95, so now 30 years ago. And then we repeated this study with a later series. You will see on the next slide, and the results were now just vice versa. So TBI had a better overall survival. And that was due that in the more recent series, which was performed between 95 and 2007, there was no longer at least up to 12 years post-transplant, but the events used to come here. There was no longer a secondary malignancy disadvantage for the TBI group, meaning that the better disease control translates into better progression-free and finally also overall survival if you use TBI instead of BEAM. So this is not translated into clinical practice because TBI became out of fashion, but this was the results of the study. So another issue is autologous transplantation good, effective in those patients who have an early relapse post-autografting? It seems that this is the case. This data is not published yet, but there are two more or less congruent studies by the Friedman and the Hideman group showing that in particular in those patients who have an early relapse after first-line treatment, autologous transplantation in follicular lymphoma is beneficial. Why is that important? Because of this study, and I think this is what we all feel is the case, meaning that those patients who have an early relapse after first-line follicular lymphoma treatment have a poorer overall survival, which is tremendous, as you can see here. And these patients are, of course, those who have an unmet clinical need in terms of relapse or rescue strategies. And here, again, autologous transplantation could come in. So what about T-cell lymphoma? Here, it's common practice, and it's considered as a clinical option in the EBMT catalog to do a consolidative autologous transplantation after in first remission, and this is largely based on two trials, and I show you one which is the largest Nordic lymphoma trial, which contained more than 156 patients with peripheral T-cell lymphoma, and they underwent a CHOP-based induction regimen, and at that stage, as you would expect, there was some primary induction failures, so they went on with 125 patients in remission who mobilized. Again, some patients did not mobilize or became progressive. So they ended up with 115 patients prior to autografting, and after autografting, still there, of course, there were some additional events. So this translated into these overall and event-free survival curves, where you end up after 5 years or so around 40% event-free survival. and this is very consistent. I won't show you all these fields in detail. This is very consistent. Here it is overall survival in all these prospective, more or less prospective trials, which are all non-comparative, by the way, which had been done in peripheral T-cell autotransplant in first remission. So what we have is this. This is a registry study by the Swedish group where autologous transplantation in first remission turned out to be a significant beneficial factor for overall survival in this multivariate analysis. But there are other data. This is also a retrospective study by the Philadelphia group showing that those patients who were in first complete remission with a peripheral T-cell lymphoma, and for some reasons, of course it's not very clear in this type of study why these patients did not get a transplant, at least they had no disadvantage not getting a transplant, because you can see this is curves with or without a transplant are more or less superimposable. And we have done more or less a similar study, just intent to treat, of all patients with peripheral T-cell who came through the door. More than 100 patients were there, or with 99 were put on this retrospective study. And for some reasons, some of these patients could not be considered for transplant. And then there was a group who could be transplanted, but for some reasons transplant was not performed, and in the other half transplant was performed. And if you look at the outcome of those patients who were not intended to transplant and those who were intended to transplant, then there was no significant difference. Again, reproducing the Philadelphia results, that this is not very clear that this is a must to do this autografting in first remission with peripheral T-cell lymphoma. What about relapse autotransplant in peripheral T-cell lymphoma? Here you can see that, again, going further down the road with the Heidelberg study. So we had altogether 87 patients in this 100-patient series who finally relapsed, so almost all relapsed, and 36 were eligible to undergo a transplant, and of these only 7 were eligible for autotransplant. All of them died, whereas half of the allotransplanted patients survived. So this led us to conclude that autologous transplantation in the relapse setting with peripheral T-cell lymphoma is not the way to go, in contrast to allogeneic transplantation. So you should ask Professor Niederwiese to introduce also the allo program here in Kaunas, for these patients at least. And this was also reproduced by the Swedish series. I will skip that in the interest of time. But the bottom line is that only those patients who underwent allogeneic transplantation in the relapse setting had a chance to survive. So what about now the standard indication for autografting in the year 2017? You can see that there's nothing left for CLL. Of course, Hodgkin still is the standard indication, first relapse or second remission. Then we have the first-line treatment in non-ALK-positive T-cell lymphoma. The same accounts for mantle cell lymphoma, whereas for diffuse large B-cell lymphoma and follicular lymphoma, standard indications are relapse settings who are sensitive. Finally, if I'm allowed, I may briefly touch on 2 contributions which were presented now at the Marseille meeting by the Lymphoma Working Party. One is HIV-associated lymphoma and autologous transplantation in the rituximab era, presented by Kai Hübel. And in this retrospective study, we included patients who were 18 years or older with a lymphoma diagnosis, who were HIV positive and underwent a first autologous transplantation between 2007 and 2013. We collected 138 patients, mostly as expected were male. The median age was quite young. Most of these patients had aggressive B-cell lymphoma, either diffuse large B-cell lymphoma, Burkitt lymphoma, or plasmablastic lymphoma. The remainder was largely Hodgkin's. Half of these patients were in complete remission and 16% were refractory at the time of autografting. Of note, 28% of these patients had only a single line of chemotherapy prior to transplant, so these were first-line consolidations. Most of these patients received beam high-dose therapy, and almost all patients continued their HIV-specific treatment during salvage and autologous transplantation. So this is the non-relapse mortality and the relapse curve, while the relapse situation is quite satisfying with only 20% relapse incidence within the first 2 years. The non-relapse mortality appears to be a little bit higher than what we would expect in non-HIV patients, but it's not tremendously high, and this translates into a nice progression-free survival of 68% across all these entities altogether. And if you break that down for the individual entities, you can see that 86% Hodgkin's and Burkitt's, where you may wonder why these patients received an autotransplant, but nevertheless they did. Probably they would have had the same outcome without a transplant, so maybe we should not focus too much on the Burkitt lymphoma patients, but the outcome of diffuse large B-cell lymphoma patients, and in particular plasmablastic lymphoma patients, I think is very encouraging, and no reason not to do transplant in HIV infected patients. This is the multivariate. I can skip that, and this just summarizes what I just have told you. So let's go finally, and then you're ready for the lunch, to the double hit lymphoma, how it is now called in the WHO classification, high-grade B-cell lymphoma with MYC and BCL2 and or BCL6 rearrangement. So this is the official term now of double hit. And this means that there is a coincidence of potent proliferation and survival signals. These patients have a poor prognosis with a standard R-CHOP regimen. There is some preliminary data suggesting that the prognosis may depend on the MYC translocation partner rather than a second hit, but that takes us too far away now. It's up to 10% of all diffuse large B-cell lymphoma, probably not so much in every series, and they have to be distinguished from double expressor lymphoma, where there is the gene product expressed, but these lymphomas are not considered as a distinct entity in the current version, which is from last year, but only as a prognostic subset of diffuse large B-cell lymphoma. So there are two series looking at transplant as a part of largely first-line treatment in double hit lymphoma. This is 300 patients from the US, and these were advanced lymphomas who underwent a standard R-CHOP, which is here down below, or a more intensive induction, sometimes including transplant, and only a small proportion, but nevertheless. And some of these also, or if not transplanted in first remission, they underwent transplant in the second line. And there was a big difference in terms of progression-free survival, but no difference in terms of overall survival, meaning that those patients who have a relapse here could be successfully salvaged. And this hints to the fact that transplant might have had some benefit, and this was also then figured out or addressed separately in the study. So those patients who underwent some transplant in complete remission were better than those who did not. This was not statistically significant, but might turn out to be so if the numbers would have been higher. Then finally a second study I think from MD Anderson. This is about 150 patients of the same age and the same mixture of risk factors, or were even worse than the previous study. And again, there were ARCHOP patients and some more intensive regimen. And again, there was a small proportion of patients who underwent primary or secondary transplant. Here you can see a significant benefit now in favor of those patients who underwent largely autograft. There were a few allografts in between. By multivariate analysis, this remains stable. So a first-line consolidation autotransplant in this study was beneficial in patients with double-hit lymphoma. Most interestingly, and in contrast to what you would expect and what we always see, is that the benefit of autografting was not in the sensitive patients. No, it was in the refractory patients. So here you can see those patients who have complete remission after first-line treatment, and there was no benefit at all of autografting. But if you look at partial remission, in particular refractory patients, you can see that the transplant patients do as good as the complete remission patients, but the non-transplant patients all die. So this is a little bit surprising. The explanation is not clear, but we won't solve it today, and for that reason, I conclude on the diffuse, on the double-hit lymphoma, that it seems that autologous transplantation is beneficial as first-line consolidation, in particular in non-CR patients, whatever the reason might be, and it might be probably also effective in the salvage setting. The role of allo over autologous transplantation cannot be answered to date. And having said that, I thank you for your attention. This is another postcard from Heidelberg. Indeed, Mindaugas Androulis was a nice collaborator. Unfortunately, he left now to Ulm, and we struggle a little bit about the hematopathology, but we will deal with it. And these are my co-workers from the EBMT, Chronic Malignancy and Lymphoma Working Parties. And of course, I thank you all for your hospitality, and Dietger, who made me come here finally.